Good
Good
afternoon,
afternoon, everyone, and thank you for joining us for the National Learning and Action Network, or LAN event, for the sponsored by the Quality Innovation Network National Coordinating Center. We're very happy to have you with us today as we discuss the important topic of patient-centered treatment options for type 2 diabetes. My name is Karen Kincaid with Television and the Quality Innovation Network National Coordinating Center. Next, a few reminders and housekeeping items before we get started today. Thank you for joining us in the WebEx Event Center. You'll need to access your registration confirmation email and unique registration ID to log into the WebEx if you haven't installed already. My colleague Amanda Ryan will be monitoring the chat board, so please be sure to participate as we go along and feel free to ask your questions in the chat. And almost all the resources and more will be shared in the event page afterwards, so don't feel like you have to copy down all the chat resources that we provide today from the chat. Slides and the recording from today's session will also be posted on the same event page. Next. Let's start by reviewing today's agenda. First, I'll go over the CE details. Then I will introduce you to each of our speakers. Patrick G. will be sharing his personal story. Dr. John Booth with the School of Medicine in Chapel Hill, North Carolina, the University of North Carolina, and Diana Isaacs with the Cleveland Clinic, who will be joining us in the panelist discussion after the presentation. She's a pharmacist and a certified diabetes educator. If we did not get your question right away in the chat or in the audio, know that we are compiling them and that we will attempt to address as many questions as possible during the discussion portion of the call. And then we will wrap up with a reminder to complete our post-event assessment. Next, I'd like to take a minute to remind our participants about the purpose of this important series of National Learning and Sharing events. Without reading all the content on the slide, I'll just mention these high points. The audience for these events is broad and inclusive of a variety of healthcare provider types, partners, and patients. The purpose of these webinars is to offer virtual learning and sharing events to focus on ideas and concepts related to healthcare quality improvement. We ask that participants think of actionable ways to implement the ideas and concepts presented today and make a commitment to share the information with your teams and organizations. And finally, we're always open to new ideas and suggestions for topics to bring to this audience, so please feel free to send your ideas through the chat and we'll see the post-event assessment. Next, we are excited to be offering continuing education credits to all attendees participating today. We offer credits to all physicians, PAs, RNs, NPs, dietitians, pharmacists, and pharmacy technicians. We also offer certificates of attendance. If you have requests for additional accreditation types, we welcome those suggestions as well, again, for our chat or post-event assessment. Next, in order to apply for continuing education credit, you must have attended the entire event, complete the post-event assessment upon exiting the WebEx, and note that the CE evaluation process only after you do the post-event assessment. For technical assistance related to the CE process, please email Stacey Davis. Her email will be posted in the chat. Next, here is a slide disclaimer from our partnering provider, CRW Associates. This activity awards 1.5 AMA credit hours for physicians and physician assistants. You may reference this slide for the full CE statement. Next, this activity also awards 1.5 contact hours for nurses and 1.5 CPE for dietitians. To follow are the accreditation statements for those entities. Right there. Okay, we're moving on to the disclosure of any financial relationships. Patrick G has none, and we would like to report that CRW Associates and the Quinn NCC, which is Television, do not have any financial relationships to disclose, nor would any commercial support receive this activity. A couple of our speakers do have some financial relationships to disclose, and you will see them on the slide. Next, And here's the further detail that spells out everything that I just said. Now, we'd like to get a pulse on who is in the room with us today. So we invite you to respond through the chat, indicating where you are working. We'll give everyone a few seconds to type in the chat what kind of setting you work in. Do you like pharmacy, psychiatrist hospital, home health, insurance, public health, skilled nursing facility, primary care, Florida Blue, that must be your Blue Cross plan down there. Okay. Thank you so much. We have F2HC, we have Quinn QIO, two Quinn QIOs. We have another health plan, provider practices. This is great. YMCA. All right. Thanks, everybody. You can keep chatting in. Next. So by the end of today's call, you will be able to discuss factors affecting treatment selection for type 2 diabetes, understand how to use or recommend SGLT2 inhibitors and GLP-1 receptor agonists in patients with type 2 diabetes, atherosclerotic cardiovascular disease, heart failure, and chronic kidney disease. Appropriately use or recommend GLP-1 receptor agonists as the first injectable for type 2 diabetes treatment ahead of insulin. And 4, share concerns about kidney health when using SGLT2 inhibitors. And 5, consider best treatment options for patients with type 2 diabetes and other comorbidities, such as hypoglycemia episodes, weight, medication costs, cardiovascular disease, and chronic kidney disease. Next. And now it is my pleasure to introduce Dr. Patrick G., Medicare beneficiary, self-employed healthcare consultant, and patient advocate. I believe the doctor is because he's got a law degree, not because he's a medical doctor. You can certainly fact check if I'm wrong. Patrick will share his story on co-managing his own type 2 diabetes with other conditions. Patrick, we are thrilled to have you here today. The virtual floor is yours.
I'd like to say good afternoon to everybody. And it's also an honor and a pleasure to be able to participate today. Hopefully, those that are listening can be able to help me and patients like me to continue in managing our care and the comorbidities that go with it. I guess to start my story, I retired after 25 years of working for the Virginia Department of Corrections, but in 2003, while I was working in the Department of Corrections, I was extremely tired. I also worked a second job in the Department of Juvenile Justice. So one day, I was feeling tired and lethargic. I went to the nurse, and she just happened to ask me if I had ever had my glucose level checked. And I was like, no. So when she checked my glucose level was 758. So at that time, she asked for my car keys and told me that if I did not get anybody to take me to the emergency room, that she would actually call the state police to actually escort me to the emergency room at the hospital. So when I went to the emergency room, they checked my A1C, and at that time, my A1C was 11.7. Diabetes ran on both my mother and my father's side of the family, but it was Greek to me at the time. I really didn't know anything about it. My parents really didn't discuss it or talk to me about any type of education. So I was referred to an endocrinologist, and the endocrinologist put me on a couple of pill forms of medication for me to take. Told me she put me on a diabetic diet. Of course, at the time, I didn't pay attention to it. I did take the medication. I ignored the advice for the diabetic diet. So basically, I was really killing myself. I ate all 3 meals late at night. So I ate breakfast, lunch, and dinner at like 11 o'clock at night, and then I went to sleep. Woke up the next morning and would work about another 20 hours between both jobs, and it was just a constant cycle. So after so many months, my endocrinologist saw that I was extremely hard-headed and put me on one insulin. She put me on Levemir. So I was taking about 50 cc's of Levemir a day. After a couple of months, my numbers still were extremely high. So she put me on a second form of insulin, along with metformin and glucotrol, I think. She put me on Novolog. So I was taking the Levemir once a day, and I was taking about 20 cc's of Novolog before each meal. Sometimes I would take it, sometimes I wouldn't, because I never ate breakfast, lunch, and dinner like that. I always combined all my meals together. So I ate a large meal and then went to sleep. That continued for a couple of years, and the ramifications from all of that was, after a while in 2013, April of 2013, my endocrinologist told me that I was at 35% kidney function, and that my kidneys were declining, and that probably by the end of the year I'd be on dialysis. See, again, because of lack of education, I really didn't know what my kidney functions actually did. So I was like, okay. They referred me to a nephrologist, and at the time the nephrologist said, well, being that you still have kidney function, we're just going to tell you to refrain from certain foods to kind of slow down when you're going to go on dialysis. So in November 2013, I remember very vividly walking into my nephrologist's office. I was 380 pounds on a 5'9" frame. It was cold outside. I outgrew all of my clothes. I had a t-shirt on, a pair of sweatpants, a pair of flip-flops, some socks, because my feet were so big I couldn't wear any shoes. And I was sitting in there basically hyperventilating. My wife told the doctor, look, my husband needs to do dialysis. When are we going to do that? So the modality that I chose was peritoneal dialysis. They scheduled me for the surgery to put in a catheter. So December 1st, 2013, I began doing peritoneal dialysis. The entire month of December, I lost a total of 57 pounds of fluid. Yet, my A1C was still hovering around between like a 9.9, maybe 10.6. So my glucose level was still high. That was because I was using dialysate, which is basically sugar water. So I still had to try to find the balance with doing peritoneal dialysis as well as controlling my glucose level. So, of course, I'm dealing with hypertension also. So my average blood pressure reading was 210 over 190. At that time, there was approximately 10 blood pressure medications, and I had made the cycle. I had taken all 10 of them, just not at one particular time, but somewhere during that span on dialysis. Also, heart disease ran in my family. Both my mother and my father and my sister both had congestive heart failure. So the physician recommended me to a cardiologist. So now I'm dealing with diabetes, type 2 diabetes, hypertension, and maybe the possibility of being monitored for any type of heart defect or potential cardiovascular disease. So going from a diabetic diet to now being on a renal diet since I'm on dialysis, it was a bit of a stretch. And, of course, I even cheated on that. So I was able to make the kidney transplant list in February 2016. I did get the first call for a kidney May the 20th, 2016. They told me that I would be getting 2 kidneys instead of 1 because of the size of the cadaver kidney that I would be receiving. They would both function as 1 kidney. And also my size, I think I was like 268 pounds at the time. And I also had a high BMI. So I go to get prepped for the surgery. They came and told me that one of the kidneys worked, the other one didn't. So they decided not to do the surgery. But because I was at the top of the transplant list, they told me that I'd probably get another call in 3 months. Well, that 3 months turned into 11 months, and I got the call April the 20th, 2017. Now, before that time, if we can go back a month to March, I was on Capitol Hill with the National Kidney Foundation doing advocacy work, and I passed out 2 times in one of the councilman's office. Come to find out, my glucose level was extremely high. I think it was around 500, and they wanted to send me to the hospital, but I kind of talked them into letting me drive back from D.C. to my dialysis center. When I got back to my dialysis center, I walked in, and my nurse told me that looking over past lab results, I was suffering from hypocalcemia, which is elevated calcium levels, for a couple of months. Then they told me that I was suffering from parathyroidism, which I had never had any problems with my thyroid before. They also thought that I may have had sarcoidosis and told me if that was the case, then I may be susceptible to either lung or bone cancer. So to get told all of this news on top of, my glucose level still being elevated was rather devastating to me. So I was recommended to a rheumatologist, and I met with the rheumatologist on April the 20th at 3:30 p.m., and the rheumatologist basically told me that the best thing for me was a kidney transplant because the only thing that they could do to treat sarcoidosis was prednisone. So I got the call from my kidney, luckily, at 11:45 that same night, and went in on the 21st, and I got my kidney transplant. The funny thing about that story is I woke up and the kidney did not. So I still had to do hemodialysis while I was in the hospital, wait for my kidney to wake up. 5 days after the transplant, they told me that they had to do a second surgery because I had a blood clot in my neck. 3 days after the second surgery, they told me that I was mixed during the second surgery, and I'm bleeding internally, so they had to do a third surgery. And they took me up to a J-tube for me to drain that. So I had that J-tube in me for 17 days, and then I ended up having a 4th surgery to get the J-tube removed and for them to create a peritoneal window. So 4 surgeries, I spent a total of 33 days in the hospital, and my kidney did not wake up until the 47th day. So after about a couple of months, my transplant center was like, well, Mr. G, you're doing fine, but you're still obese. Your glucose levels are still high, even though you're taking your insulin properly. and your prednisone medication has been decreased. So they recommended me to go to the weight loss clinic in the same hospital. The weight loss clinic put me on the ketogenic diet, and they geared it toward my diabetes. So they explained to me about the diet, which was 70% fat, 25% protein, and 5% low carb. So, I eat no more than 20 grams of carbs a day. They took me off of all my insulin when I started. The 16th of this month would be a year that I've been on it. I've lost a total of 63 pounds. I just had my A1C done last Friday, and it was 4.8. So now I know how to manage my diabetes. My average blood pressure level averages like a 123 over 72. So now, because I have a healthier lifestyle, it has allowed me to not eat certain foods that I was accustomed to eating. I exercise 3 times a week just to get in shape. And this year, I believe in April, I'm going to run my first 10K. And I'm running for those folks that are still battling diabetes, hypertension, the comorbidities that actually lead to kidney disease. So that's my story in a nutshell. I went from being hard-headed to now having a more healthier lifestyle.
Patrick, wow. Wow, that just gives me chills. I've heard the story before from you a couple months ago. It's awesome. And really, the exercise is awesome, too, because that's going to help you keep that weight off. And what an advocate. And now your blood, the A1C is normalized, your blood pressure is normalized. You must feel a lot better, too.
Yes, and one of the biggest things, if I can just add this last piece, one of the biggest things out of all of this is that my doctor said that I'm no longer considered obese. I think my BMI is like at a 28. So that's probably the most happiest thing for me, that I'm no longer considered obese.
That's great. That's great. You reduce your risk of a lot of things going down the category from obese to overweight. That's really great. And you're getting a lot of positive comments in the chat. You can't see it. You've got a woohoo. Love those numbers. Wow, what a journey. Thank you for sharing. Wow, what an amazing story. Thank you, Patrick, for sharing your journey with us. Your perspective is so important for helping others manage their chronic diseases. And congrats to you for achieving all your health milestones. Good job on the positive changes that you've made. There's so many comments. This is great. So awesome, and such dedication to your health. Awesome turnaround. Nice work. We can probably just send you all these comments after the webinar. And everyone's going to have a chance to ask him questions at the end as well. So maybe let's go on to the next slide. And I'd like to introduce our main speaker for the day, Dr. John Booth. Dr. Booth is the Vern S. Kavanagh Distinguished Professor, Chief of the Division of Endocrinology, Director of the Diabetes Center, Director of the North Carolina Translational and Clinical Sciences Institute, and Executive Associate Dean for Clinical Research at the University of North Carolina School of Medicine in Chapel Hill. Dr. Booth completed service as President for Medicine and Science at the American Diabetes Association in 2008 and as Chair of the National Diabetes Education Program since 2014. He has received numerous awards and honors, including the 2010 Castle Connolly National Physician of the Year Award. He has authored more than 300 publications. I greatly shortened his bio, as you might imagine. Thank you for being here, Dr. Booth. The floor is yours.
Well, thank you very much for your kind introduction. And though I had said hello to Patrick before, I hadn't heard the story. I think my presentation might be anticlimactic. It is largely focused on drug therapies and diabetes, but I do, first of all, Patrick, I'm so glad that you are well now. I think the best path forward is to try and prevent chronic kidney disease and cardiovascular disease in the setting of diabetes. And that's really the message for today, that based on drug development and new clinical trial data, I do think that there's a path forward to prevent those outcomes that afflict so many people with diabetes. So we're going to be mostly focused on talking about two classes of drugs. The GLP-1 receptor agonist, which you'll often see abbreviated as GLP-1RA. It's an injectable class of medications. It's not the same as insulin, but it can be mixed with insulin. There's 6 of them on the marketplace in the United States. Byetta is the original version. It's dosed twice a day as an injection. There's a once-weekly formulation of exenatide, which is called Bydureon. Liraglutide is called Victoza, and it's a once-a-day injection. Semaglutide is Ozempic, and dulaglutide Trulicity. Those are once-a-week injections. And then lixisenatide, or Elixin, is largely combined as a pre-mixed formulation with insulin. And then we're also talking about the SGLT2 inhibitors, and that stands for sodium glucose cotransporter 2. It's a pill administered once a day, and there are now 4 on the market. Canagliflozin, which is Invokana, empagliflozin, which is Jardiance, dapagliflozin, which is Farxiga, and erdagliflozin, which is Steglatro. So usually in these medical presentations we use the generic names, and hereafter I will. But that's just to introduce the brand names that are often more commonly recognized. And certainly, if you're watching television, many of these products are being advertised. One hint that you might have picked up on is that in general, the GLP-1 receptor agonists end in tide, and the SGLT2 inhibitors end in flozin. And if you remember that, it may help you keep track of stuff moving forward. This just introduces the topic I was given, management of hyperglycemia and type 2 diabetes in 2018. There's a recently published report from the American Diabetes Association, the European Association for the Study of Diabetes, and 90% of the slides that I'm going to show you were derived from that report. I chaired the American delegation to that group of 10 who developed the report. Our unit at the University of North Carolina does a lot of work with the pharmaceutical industry. These are contracted with the University of North Carolina and have not to date provided me direct financial benefit, but obviously it's a big part of my work and my success. Here's a screenshot of the 2 papers that are published. Each of them is 37 pages long. I get about 30 minutes to review that, so this is going to be a very top-level review. I would encourage you to look at them if you would like additional details. I'm biased, of course, since I participated in writing them, but I do think it's chock full of information, and I'll try and highlight some of those additional bits of information as we go through the presentation. Both of the publications, they're identical. One has sort of more British spelling than the other. The words otherwise are identical, and both are available for free online. So the key points of new emphasis here, because this paper basically has been redeveloped every 3 years, so the first iteration in 2012, the last one in 2015. Here in 2018, there was a greater focus on lifestyle interventions. That's always been the cornerstone of management of diabetes, but based on new data, it's absolutely clear that lifestyle management can work, as you heard from Patrick. And I think for patients and for providers, you just have to believe that it can work and keep pushing forward to find the lifestyle plan that works. And that includes medications that are available for weight loss, as well as metabolic surgery. But as you heard from Patrick, there's certainly more pure lifestyle approaches that work. Secondly, there's a greater focus on recognizing that patients are the cornerstone to getting this done. Patrick reflected to you that he was hard-headed in the beginning. You know, maybe I would put it that he wasn't adequately inspired, but because it's so essential what a patient does, the biggest issue is working with patients to develop a plan that they can actually execute. The biggest new part is about these recent trials that demonstrate the benefits of GLP-1 receptor agonists and SGLT2 inhibitors in preventing cardiovascular disease and chronic kidney disease outcomes. And perhaps the most controversial bit is that for patients with type 2 diabetes, we recommend glucagon-like peptide 1 or GLP-1 receptor agonist as the preferred initial injectable therapy over insulin because they're not associated with weight gain and not associated with low blood sugar, and as a result, we can push a little bit harder with them to reduce blood sugar overall. So here you see the central part of the central figure of the paper, which posits that the patient is really at the center of care. We cannot forget that. I think the biggest failure of the healthcare system is that we too often tell patients what to do, which in this kind of chronic disease where patients have to be on top of their disorder 24 hours a day, 7 days a week for the rest of their life, you just can't tell people what to do. Nobody is capable of doing what you tell them to do. You really need to enter in a negotiation. And here is the outline of that path of negotiation, which we call a decision cycle. It's based on the goals of care to prevent complications and optimize quality of life. And it starts from understanding what's special about an individual patient. The treatment plan is going to be very different for someone like Patrick who eats 1 meal a day than the average person who may eat 2, 3, 4, 5 meals a day. We need to think about specific factors that will impact what treatment we choose. We might choose a different drug for someone that's heavy than someone who isn't. Obviously, we're going to talk a lot about choosing different drugs in people who have cardiovascular disease or chronic kidney disease. And then the idea is that the provider and the patient need to engage in a process of what we call shared decision-making to create a management plan, basically a plan that both the provider and the patient are on board with being a reasonable approach, at least to start. So then there's an agreement on the management plan. The patient is encouraged to implement that management plan with their team behind them. That includes family members, co-workers, friends, and the providers who are providing ongoing monitoring and support. And then on a frequent basis, maybe in the beginning, every few months, in the long haul, at least once a year, to review the plan, how things are going, and decide on how to tweak that moving forward. This slide is the full figure, the first figure of the paper, and it just fleshes out some of the details around things that should be assessed in each of those areas in developing and implementing that management plan. So the second section of the paper, and again, the bulk of the paper is focused on the new evidence from cardiovascular outcome trials and where does it fit in the treatment recommendations from the American Diabetes Association, the European Association for the Study of Diabetes. And starting in 2015, we had recommendations that certain comorbidities or conditions other than just type 2 diabetes should influence the choice of particular glucose-lowering medications. So lifestyle's always been the cornerstone of management, the foundation on which the whole plan is built. But as you go to medications, in the past we suggested specifically tailoring those medications in patients where obesity is a major issue, in patients where hypoglycemia or low blood sugar is a particularly worrisome complication of drugs, and in patients where cost is really a compelling issue. And what's new since 2015, or with this new guidance for this year, is that in patients with type 2 diabetes with established atherosclerotic cardiovascular disease, so heart disease, stroke, peripheral vascular disease affecting generally the legs, then in those patients we should use a sodium glucose cotransporter 2 or SGLT2 inhibitor or a GLP-1 receptor agonist that has proven cardiovascular benefit as part of the management plan. So step one in thinking about the drug therapy of type 2 diabetes is to define whether the patient has cardiovascular disease, heart failure, or chronic kidney disease. And we generally divide those people who have those problems into two buckets. People who predominantly have a problem with cardiovascular disease, so these would be people with recurrent hospitalizations for chest pain or stents to relieve blockages, or heart attacks or strokes or transient ischemic attacks, or patients where heart failure and chronic kidney disease is really the predominant problem. And the reason why we divide them that way is the drugs seem to have relatively greater benefit in one or the other. So if atherosclerotic cardiovascular disease predominates in a patient, so let's say someone who's had a heart attack and required bypass surgery and continues to have some problems with angina, that would be a patient in whom the heart disease seems to really predominate. The recommendation is to start with a GLP-1 receptor agonist with proven cardiovascular benefit. And we said that the evidence for benefit is greatest for liraglutide, similar for semaglutide, and both of those a bit greater than exenatide in the once-weekly formulation. Or you could use an SGLT2 inhibitor with proven cardiovascular benefit, and there we felt that empagliflozin has evidence for greater benefit than canagliflozin, though they're quite close. And since we published this paper on October 5th, there's new data from dulaglutide and dapagliflozin, and because we haven't reconvened the committee, I can't really tell you where it would fit in the hierarchy, but certainly they would be among the recommended agents. And then in patients with cardiovascular disease, and that's a very important caveat, so in patients who have cardiovascular disease, prior heart attacks, prior strokes, bypass surgery, known blockages, who have heart failure in addition, the recommendation is to start with the SGLT2 inhibitor. So patients with type 2 diabetes are at increased risk for heart failure. The trials with the SGLT2 inhibitors consistently demonstrated benefit for heart failure. The trials weren't done perfectly as far as heart failure goes, but the evidence is so clear across the trials that we felt comfortable making that suggestion. In patients who don't prefer to use an SGLT2 inhibitor or can't use an SGLT2 inhibitor, the GLP-1 receptor agonist with proven benefit would be a good alternative. With regards to this set of data, one thing that's missing is that in the trials, there were patients who did not have cardiovascular disease when they entered the trial. And in those patients, who were a minority of the patients in the trial, there was no benefit on heart attack, stroke, cardiovascular death. And therefore, we don't really make these recommendations for the general population of people with type 2 diabetes, only for the patients with cardiovascular disease with or without heart failure. And I'll come to chronic kidney disease in a second. And then secondly, you might notice if you went further down in the figure that we recommend if one of these drugs isn't enough to control the blood sugar, that you would add the other. I have to admit that we don't have great evidence to support the benefit of that combination with regards to further reducing the risk of heart disease. We do know that that combination is effective in lowering blood sugar without increasing the risk of hypoglycemia and while promoting weight loss. And here's just an example of one of the trials with the SGLT2 inhibitor, here looking at hospitalization for heart failure, and you can see in the red line, empagliflozin, the SGLT2 inhibitor, was associated with a much lower event rate over time of heart failure hospitalization. So you need to treat 71 patients with an SGLT2 inhibitor over 3 years to prevent a heart failure hospitalization. And then also new since 2015 is a focus on people with chronic kidney disease, like Patrick was very near after he was diagnosed with diabetes. And that is that for patients with type 2 diabetes and chronic kidney disease, with or without cardiovascular disease, consider using an SGLT2 inhibitor. It's been demonstrated to reduce the rate of chronic kidney disease progression. And if it's contraindicated or not preferred, you could use a GLP-1 receptor agonist. So this is very much like the recommendation for heart failure, except you don't have to have cardiovascular disease for this to apply to you, only the presence of chronic kidney disease. And that's because these medications have shown to have benefits. Now, there are a couple of issues, and that is that these medicines generally aren't recommended in people with advanced kidney disease. There's something called the estimated glomerular filtration rate, which is, I think, where Patrick was I don't remember exactly the timing, but the early 2000 teens, where he had a third of normal kidney function. So that's actually the lowest level that this has been studied at to date. And so with more advanced kidney disease than that, we don't really know that there's benefit. And here's just an example from the EMPA-REG trial. Again, the empagliflozin, the SGLT2 inhibitor, you can see is associated with a lower rate of a renal event, and here is defined as a doubling of the creatinine level or the need to start renal replacement therapy like dialysis or transplantation, or death from kidney disease. And you can see that there's nearly a 50% reduction in the rate of progression of kidney disease with the SGLT2 inhibitor in this study. And here from the LEADER trial, a study with a GLP-1 receptor agonist, evidence of benefit on reducing the rate of development of kidney disease. But here, the outcomes were what we call softer, so largely a benefit on protein in the urine, less evidence of benefit on doubling of serum creatinine or developing end-stage renal disease needing dialysis or transplantation. And so that's why we prioritize using an SGLT2 inhibitor over a GLP-1 receptor agonist. And then lastly, because patients who have chronic kidney disease or heart attacks or strokes or other cardiovascular diseases sometimes or are already being treated with their diabetes, we had to give some recommendations around what to do about the medication management. So this is all about medication management to reduce hemoglobin A1C or improve blood sugar control. And so it says that if a patient's blood sugar control is inadequate, that in general you would continue metformin, or if they hadn't been started with metformin, to start metformin. And then if the hemoglobin A1C isn't a target, to add an SGLT2 inhibitor or GLP-1 receptor agonist. If the A1C is at target, we give 3 options there. One, if they're on 2 drugs, and you could stop the one that's not associated with benefit and start one of the ones that is associated with benefit. Or you could lower the target
or you could just follow patients every 3 months as we normally do, and then add the SGLT2 inhibitor or GLP-1 receptor agonist later. So to summarize that part of the talk, it's essential early in the course of managing patients with diabetes now to consider whether the patient does or doesn't have atherosclerotic cardiovascular disease, chronic kidney disease, or heart failure. The general recommendation is that everybody should start with metformin if they tolerate it. If patients have atherosclerotic cardiovascular disease, adding a GLP-1 receptor agonist or SGLT2 inhibitor is recommended if needed to reduce blood sugars. And in patients with heart failure, an SGLT2 inhibitor is recommended if they also have atherosclerotic cardiovascular disease. If they have chronic kidney disease with or without cardiovascular disease, consider using an SGLT2 inhibitor. In each case, you want to use an agent with proven benefits from a clinical trial. So then the rest of the paper, or almost all the rest of the paper, is about what are the full array of choices we have in managing diabetes, and how do we put it all together. And I won't go through the full array, but just to point out that lifestyle, again, is the cornerstone, and that's both medical nutrition therapy and physical activity, medications, including medications for weight loss, and then metabolic surgery. And I would just point out that it's really lifestyle management and metabolic surgery that have been demonstrated to cause the sort of reversal or remission of diabetes, like Patrick has exhibited on the ketogenic diet with his diabetes basically going away, and I assume that it will stay away as long as he stays on that lifestyle plan. So the giant table that covers 7 pages that goes through all the advantages and disadvantages of the various treatments, including the lifestyle choices, the drug therapies, and metabolic surgical techniques. And I think that table can be very useful to providers and perhaps even patients. And then the last piece is putting it all together. How do we implement things? Again, it is absolutely essential to go through this cycle of patient-centered shared decision-making in developing the plan. I'm not advocating that all the providers on the phone, that every patient with cardiovascular disease, you just write a prescription for a GLP-1 receptor agonist or SGLT2 inhibitor. It's a matter of negotiating with patients what the advantages and disadvantages of your approach are and why you might be recommending it, and making sure it fits into their overall plan, etc. So again, the foundational therapy is metformin, based on a long-standing, 50-year history in Europe, showing that it's effective, safe, generally well-tolerated, and very inexpensive. There are some studies that suggest that there are cardiovascular benefits to metformin as well, and that's why we continue to recommend it as the first-line therapy in most patients. In general, we recommend that you would start with one drug in a patient with diabetes. Though some people advocate for using combination therapy early on, we felt like it wasn't really proven that that approach provided additional benefit. The one setting where we would support using 2 drugs right from the get-go is in patients whose blood sugars are very high at the first visit, particularly if there's concern that the patient may not come back in a timely way to reassess and add another medication. But in general, starting with one drug after a lifestyle effort is reasonable. And then there's this giant figure that, again, starts with lifestyle and then metformin. If additional glycemic control is needed, first of all, to determine whether the patient has established atherosclerotic cardiovascular disease or chronic kidney disease. We've already covered that. And then next to it, section for those patients without established atherosclerotic cardiovascular disease or chronic kidney disease. And then that is divided into three sections. The first we'll go through in more detail in a second, patients who have a compelling need to minimize hypoglycemia. Second, patients who have a compelling need to manage weight and promote weight loss. And the third section where cost is a major issue. And so to go into those subsections in a little bit more detail, beyond metformin, there's actually 4 classes of drugs that are not associated with hypoglycemia. And hypoglycemia could be a big deal in an airline, a commercial pilot, or someone who serves in the military, police officer, people doing construction work, basically situations where low blood sugar could be associated with harm to themselves or to others in association with loss of consciousness, that sort of thing, or impaired consciousness. You might notice that 2 of the drugs that are on there are the GLP-1 receptor agonists or SGLT2 inhibitors we talked about before, but also the DPP-4 inhibitors and the thiazolidinediones. And then in the section about weight loss, there's the recommendation on the right, just to remember that if weight is a big issue, remember about the lifestyle advice. Remember what Patrick has told us today, talking about non-surgical energy restriction for weight loss, including things like meal replacement therapy. If none of that works, remember metabolic surgery is highly effective and certainly should be at least mentioned to patients as an option if needed to enhance control of cardiovascular risk factors. There, again, it's the GLP-1 receptor agonists and the SGLT2 inhibitors that have the greatest benefit. And I would just point out in footnote 1 there, a hierarchy in the GLP-1 receptor agonists with regards to their effectiveness for weight loss. So there, semaglutide has the best data, better than liraglutide, which is a bit better than dulaglutide, which is substantially better than exenatide or luxesenatide. And then finally, when cost is a major issue, which is a big deal for many, many patients in the United States, I actually personally think that access to care is the biggest problem we have in diabetes management in the United States. Metformin is generally quite inexpensive. The sulfonylureas and thiazolidinediones likewise are quite inexpensive. If a combination of those agents isn't enough, we point out that basal insulin, like NPH insulin, can be very inexpensive. So specifically at Walmart, the store brand, which can be obtained without a prescription, is $28 a bottle, as opposed to up to $300 for a pack of insulin pens for some of the branded insulins. There's been a lot of stuff in the press about insulin prices, and I do think it's absolutely essential that every person with diabetes in the United States know that they can get insulin for $28 a bottle at Walmart without a prescription when they get into trouble. And then lastly, in patients who need the greater glucose-lowering effect of an injectable medication, again, we recommend using a GLP-1 receptor agonist as the preferred choice to insulin. The rationale for that really is that the GLP-1 receptor agonists are not associated with hypoglycemia. They're associated with weight loss instead of weight gain, and in head-to-head studies are just as effective, maybe even more effective than insulin with regards to glucose lowering, unless there's a concern that the patient actually has type 1 diabetes. In type 1 diabetes, insulin is life-saving and must be used. And then lastly, there's a panel about what medications to continue once you go to injectable therapies. And I won't belabor the point here. There's a lot of detail. But in general, metformin and the SGLT2 inhibitors are generally considered appropriate in the setting of injectable therapies. So to summarize, the management of type 2 diabetes has become complex. We have like 10 classes of medications. Patient-centered decision-making and support are really essential for success. It doesn't matter how good the drugs are unless we can figure out how to help patients manage the diabetes themselves. Metformin remains the initial therapy, and we can recommend further therapies from there based on these comorbidities, generally narrowing the choices to 2, sometimes 4 agents in those settings. So I did want to briefly go over a case in a couple of different flavors. So this is a 55-year-old with a 10-year history of type 2 diabetes. They had coronary artery bypass graft surgery 5 years ago. Their A1C is 7.5%, so the general target is 7%. The current treatment for diabetes is metformin at a full dose and glynepride at an effective dose. All the cardiovascular risk factors are well managed. The patient doesn't have any evidence of heart failure or kidney disease. And the question is, what do you do next? So do you add a GLP-1 receptor agonist with proven benefit, an SGLT2 inhibitor with proven benefit, pioglitazone, that's brand name Actos, there's a cardiovascular outcome trial with that, or either a GLP-1 receptor agonist or SGLT2 inhibitor, or none of the above, that the diabetes control is adequate, and really what you want to do is talk it over with their primary care doctor, endocrinologist, and or the patient. So if you could vote, we'll have a chance to go over the results in a second.
Yes, everyone, you should see the poll in your right-hand side of your monitor. And you do have 20 more seconds to make your selection. Okay, it looks like it's been closed already. And we'll just wait for the results. So it is the WebEx, so it's going to pull up the results. There we go. We had a lot of shy folks out there.
Okay.
273 didn't answer, but we had 22 said none of the above. Diabetes control is adequate. And we do serve senior population, like I heard.
Yeah.
That's not surprising. We had 16 that said GLP-1, either GLP-1 or SGLT2 inhibitor with proven cardiovascular benefit, and 16 said the first choice, GLP-1.
Yeah, and just to reflect on that, I do think for people with heart disease, the GLP-1 receptor agonists and SGLT2 inhibitors are great choices. The evidence of benefit for preventing heart attack, stroke, and cardiovascular death is arguably stronger for the GLP-1 receptor agonist. We balanced it in the recommendations, but personally, I think there's a bit more evidence that A might be the ideal answer. B is certainly an acceptable answer. 4 or D is arguably the best answer, but even number 5 is a not unreasonable answer. Talking it over with the team, some people feel that 7.5 is great. I think in a person with cardiovascular disease, having the opportunity to reduce the risk of cardiovascular disease is a compelling indication for using GLP-1 receptor agonist or SGLT2 inhibitor. So the second case is really the same case. Now the only thing that has changed is now the patient has heart failure with a reduced ejection fraction. They also arguably have chronic kidney disease. Their estimated GFR is 65, so that makes it stage 3 chronic kidney disease, and they have an increased urine albumin to creatinine ratio, so they have clinical albuminuria. So this is a patient who has both cardiovascular disease and heart failure and chronic kidney disease. and to do the poll again, same answers. I won't read them again, but GLP-1 receptor agonist, SGLT2 inhibitor, pioglitazone, either of the GLP-1 or SGLT2 or none of the above. So why don't you enter your answers?
All right, time's up. Our results should be shown here in a moment. And Dr. Booth, you can see those results, right? So go ahead.
Yes,
and
I can.
walk through it.
Good. I can see the results when they come, but there you go. So not as shy this time. So the leading vote getter was an SGLT2 inhibitor. I do think that's the single best answer. Answer 4 came in second, either one. In a way, that's true. We have a preference for using an SGLT2 inhibitor in people with chronic kidney disease and in patients with heart failure, but the GLP-1 receptor agonist would be the sort of second choice in that setting. And then the third most answers for the GLP-1 receptor agonist, I think I covered that adequately. So it's not a terrible choice. I think the SGLT2 inhibitor is the best choice in this setting. And the third one is meant to just spark a little bit of controversy. So here the patient's hemoglobin A1C is 6.9%. So otherwise the same cases we just went through a moment ago. So it really gets at the issue that drug therapies that we're recommending are really primarily aimed at improving glycemic control. What are you going to do in the patient who arguably their diabetes is well managed? And so the answers are the same. So GLP-1, SGLT2, pioglitazone, either one or none of the above. So enter your answer here. So we should have the answer come up in a second. So this will be my last comments before the Q&A. I do want to apologize for going over a bit in my presentation. So here, the leading vote getter is none of the above, which I do think is probably the best answer. There is an option that's provided in the guidance that I briefly went over because the patient was on sulfonylurea, which is a drug that's not known to have cardiovascular benefit. You could stop the sulfonylurea and start an SGLT2 inhibitor or GLP-1 receptor agonist. But I do think of the choices that you're given, arguably the best one may be number 5. Though certainly there are alternatives. So maybe I'll end there and we can go to the Q&A section. Thank you so much for listening.
Thank you so much, Dr. Booth. Are you going to be able to stay on until 4:25?
Yes, I will.
Great. So we have, on our next slide, we have Patrick G. and we have Dr. Booth, and we have Diana Isaac of Farm D, CDE from the Cleveland Clinic, who's also practicing at the Cleveland Clinic Diabetes Center. And I'll read you a little bit of Diana's background before we get to the Q&A. She's a clinical pharmacy specialist there at the Cleveland Clinic. She's board certified in pharmacotherapy and advanced diabetes management and a certified diabetes educator. She enjoys working on an interprofessional team and has established several several clinical services within the Cleveland Clinic Diabetes Center. She is involved in a robust shared medical appointment program and coordinates the continuous glucose monitoring program. And I know you stay up on all the medications because I heard you speak at AADE last August. We would like to take this time to answer anyone's questions out in the audience. If you've posted anything in the chat, or if you would like to verbalize your question in the phone line. So I'll first ask our operator, Chris, do we have anyone that is press star 1 and is waiting to ask their question on the phone line?
Ladies and gentlemen, at this time, I would like to remind everyone, in order to ask a question, please press star, then the number 1 on the telephone keypad. We will pause for just a moment to compile the question and answer roster.
And while we're waiting on the queue on the phone, Amanda Ryan is our chat monitor. He's had a very active chat. So, Amanda, are there any questions you'd like to pull out?
Sure. Thanks, Karen. There's actually been several. The first one is for Patrick, and this question came from Susan. She asked, was there someone who helped you to realize that you needed to change?
One of the nurses at the transplant unit, kind of pulled me to the side away from everybody and told me that she had gone to the same weight loss clinic when she was diagnosed as being borderline diabetic. And she just told me that I'm getting a second chance at life. I need to fight to keep this kidney. With everything that I've gone through, it would be, very, it would be stupid of me to go back to that same lifestyle after everything that I've gone through. So that kind of shook me to the core a little bit and just allowed me to pay, more attention, things that I didn't pay attention to when I was younger. So I would attribute it to my transplant nurse.
All right, thank you, Patrick. Karen, we got a couple more questions. Do you want me to do those, or do you like to go to the phone line?
Let's check the phone line since it's been a minute. Chris, do we have any questions on the phone?
Presenters, there are no audio questions at the moment. Please continue.
Okay, Amanda. Go ahead and see what's in the chat.
Okay. We have a question about a diet question. I think that could go to any panelist that's comfortable answering this one. The question is from Jerry, and it is, so is the new diabetic diet the ketogenic diet? Thought that there was no specific diet that the ADA sanctioned.
Yeah, maybe I'll take that. We can get other people's comments. So the questioner is absolutely right. There is no ADA diet. The diet that Patrick used was the ketogenic diet, and it worked really, really well for him. So the recommendations for the American Diabetes Association are to develop a lifestyle plan that works. And frankly, I think the obesity management experts have understood this for some time, that often you will develop a lifestyle plan. It either sounds good to everybody involved. When the patient gets home, it turns out it's not something that they can adhere to. It doesn't work with their family or whatever. And so there's always a process of trying different things. The ketogenic diet is one that some people find very useful. It's not the most commonly recommended diet in obesity management or in diabetes management, but certainly it's a major force out there.
All right. Thank you so much, Dr. Booth. Next question comes from Carmen, and Dr. Booth, this one sounds like it's for you as well. She would like to know if the recommendations change if the patient has liver disease, either with or without kidney disease.
Yeah, the group of 10 of us that wrote this guidance, we did talk specifically about liver disease. The issue is that the studies haven't been done, there haven't been enough studies with enough patients followed for long enough to make a strong recommendation. There is some evidence that among the diabetes medications that pioglitazone is associated with benefits in patients with liver disease. There's some evidence that the GLP-1 receptor agonists and the SGLT2 inhibitors have some specific benefit in patients with liver disease. And that level of evidence is sort of declining as we go through that list. So greatest for pioglitazone, less for GLP-1, less for SGLT2 inhibitors, but those three more than the rest. Lifestyle management is really important for the typical liver disease in diabetes, which is related to obesity, and it's a whole other 1-hour presentation.
All right, thank you, Dr. Booth. Karen, do you want to check the phone again?
Yes. If you'd like to ask a question, go ahead and press star 1 on your telephone keypad. And Chris, do you have anybody waiting?
There's still no question at the moment. Please continue.
Okay. And Karen, this is Karen, the facilitator. I'm a dietitian and CBD by background. I just want to point out on the diet question too, there's a whole section, to back up what Dr. Booth said, there's a whole section about diet and lifestyle in the ADA Standards of Medical Care for Diabetes that Amanda has posted. And there's no magic percentage of protein, carbohydrate, and fat. A little higher carb works better for some people, and lower carb works better for other people. So, beyond the science, there's an art to figuring out what works for each patient.
And maybe it's worth getting Patrick's comment, because at least in my patients that do the ketogenic diet, it is very effective for promoting weight loss. But, in 21st century America, it's often extremely difficult to stay on a diet with 5% carbohydrates. Patrick, how do you do it?
Well, it's known that the ketogenic diet isn't a long-term diet. And depending on, I'm still 15 pounds short of my actual goal weight. So once I hit my goal weight, then I would stay in the management phase, which means that I can increase my carbs, but it will be only the good carbs. From what I've researched and studied, it's going to be trial and error. Basically, what works for you. Like for me, the ketogenic diet is a very disciplined diet. I haven't had fruit in a year, and a lot of dietitians will tell you, you need to eat more fruits and vegetables, but they didn't want me to eat fruit until I met my weight goal because of the diabetes. So that's how I've had to manage my lifestyle.
Yeah, and it sounds like you've gotten really close supervision too with your diet, which is really important if you're extremely, going extremely low on carbs.
Yeah, there's, we have a support group. Even the physicians that actually supervise us are on the same diet. All the nurses, the PAs, everybody in that unit, and from that they started a food as medicine program where they're trying to gear dietary nutrition to fit every illness that's out there. So they're trying to work on a diet for sickle cell anemia, they're trying to work on a diet for hypertension, various things. So that's still in the research phase, but I know that the hospital that I'm at is getting ready to go sugar-free this year, which is going to be extremely interesting, to say the least, for the entire hospital to go sugar-free. That's going to be interesting. I really want to see the outcome of how that's going to affect non-diabetics and diabetics.
Like a no added sugar thing where we can have natural carbs but no added sugar. That'd be interesting.
Yeah, we tried to do something, or some of us at UNC tried to do something in that space and kind of hit a brick wall.
I can imagine.
Yeah. Good luck. So
I
saw a few questions about metformin, and maybe I just point out that, so a couple people raised issue about the GI side effects of metformin, and it is about 20 to 30% of patients have some GI issues, but they're usually most prominent in the beginning, for the first few days or maybe a few weeks. And it can be minimized by starting with a single tablet once a day taken with food. And then after a week or so, if people are doing well, taking one tablet twice a day and going up from there. So over 80% of patients can tolerate it quite well, what we call an effective dose, which is generally at least 1,000 milligrams a day. But you're right, some people cannot tolerate it at all.
This is Diana. Yeah, it's a pleasure to be here, and I just wanted to add too with the metformin, we found, using the extended release that people tend to do a lot better with that. So if you had kind of those GI problems before, that could be something good to try to be able to tolerate it a little bit better.
And also, 500 milligrams for a week and then go up on the dose later, if the doctor isn't titrating it according to the recommendation, that could cause them to have side effects out of the gate if they're getting too high of a dose at the beginning. We have a ton of questions in the chat, so Amanda, do you want to check out another one?
Yes, I've got several more. So this next one comes from Marcy Brown, and I hope I'm saying that name correctly. The questioner says, "Hi Patrick, like you, I am an educated 50-year-old African-American male with type 2 diabetes. However, I was ignorant to diabetes. Can you speak to the audience about what socioeconomic factors contributed to your situation and how important that is, particularly for underserved populations?"
Yes, I will definitely do that. There was no nutritional education when I grew up. And of course, for me, watching my parents who came from the rural area cook, and a lot of recipes passed down generationally, most people of color don't want to change how they prep food and stuff like that because they don't want to lose the flavor of the food. So for me, I had to learn a different way of still maintaining the flavor, and just trying various recipes. But I do know for people of African descent that are most affected with kidney disease, which is Africans, African Americans, Afro-Latinos, and Afro-Caribbeans. There's not a lot of pre-diabetes education that they're getting either from primary care or from community fairs, anything like that. A lot of low-income areas have maybe corner stores that are not grocery stores, so they tend to sell, some of, not the best fruit in the world, maybe not the best grade of vegetables or anything like that. And, you know, when you're dealing with a chronic disease, you know, it's bad. There was somebody that posted on Twitter yesterday that one orange costs $1.49. What do you do with a person that can't afford it? And I know people that's on dialysis that are type 2 diabetic that have to flip a coin. Do I buy this orange because I'm hungry? Or do I put gas in my car? Or do I pay my rent? Or do I get my medication? So when you have people that's making life-threatening decisions just to try to get healthy, 9 times out of 10, they're going to eat unhealthy and put their money where they think is most important. So I really think if we can get out in those communities and do some serious education and to even, maybe to get providers to kind of chip in, agriculturalists, maybe to help or teach people how to maybe grow their own fruits and vegetables and stuff like that. And, maybe that's one step to getting people to eat better and to live healthier lifestyles. But I know for myself, it wasn't until late in life, because I'm 55 years old now, and I was never sick up until I got diabetes and stuff like that. And, you always sit back and wonder, if I knew then what I knew now, would I really change? And the answer is yes. So I think right now with the new millennial generation, we really need to get out there in the community, to kind of educate people on, the proper nutrition, dieting, and the benefits that, it would have for your heart and to do away with diabetes.
Great point. I mean, the culture we grew up in, and Marcus Brown said also, nutrition was never discussed at his dinner table. So there's another place that you can have great influence on our children before we, grow up into older adults with these tastes that are bad for us. Amanda, I saw a question from Neeraj Iyer recently. This might be a good question to end on. I also would like to hear from Diana Isaac first if she has any expert, opinion about the consensus recommendations that were shared today, based on your experience as a pharmacist, CDE, with SGLT2s and GLP1s, which are the newer classes of medication.
Yeah, happy to address that. So, with the GLP-1 agonist, one thing that is an important consideration is that all the devices are actually a little bit different. And, they work differently in terms of some are once weekly versus some are once daily. So what I really like about the new guidelines is that it stresses shared decision making. And I think it's really important when you have that patient in front of you to talk about some of those differences. Like with Trulicity, for example, you don't see the needle. Same with the extended exenatide now. There's a version where you don't see it versus others where you have to attach the needle. Some come with them, some you have to order separately. The size of the needle can be a little different. So those are some things that are good to take into consideration. Another thing, which I think I saw this in one of the questions, is the cost issues. Unfortunately, there are patient assistance programs, but those are usually for people without insurance, or there's very restrictive criteria for people with Medicare. So they can be pretty challenging to afford, and there are copay cards, but those are only for people with commercial insurance. So there's really, no one-size-fits-all, and unfortunately, we can't use them for everyone, even though we know that people may benefit from them. So those are some of the, considerations. And then also just in terms of the counseling points, too, SGLT2 inhibitors can cause dehydration, and so it's just so important to let people know, drink plenty of water and the things that they may expect to see when when they're going to be started on a new drug. And I'd like to put a plug in for diabetes education too, because I know that oftentimes our doctors, our providers only have 20-minute visits, maybe if they're lucky 30 minutes, and so that's often not enough time to, go over all the effects of the drugs and all the other lifestyle changes and stuff. So.
Thanks, Diana. I think we'll end on the question from Miraj Iyer in the chat. Says, Dr. Booth, what recommendations would you have for health systems who are looking to make population-level decisions regarding care for diabetes patients in the light of these new recommendations from the ADA?
That's a great question. So one thing that we're starting to work on here at UNC is developing what we call a computable phenotype. So the idea is to develop a algorithm using information that would be in the electronic health record about what kind of diabetes someone has. Do they have clinical cardiovascular disease? Do they have a diagnosis of heart failure? Do they have chronic kidney disease? And basically putting in, creating messaging around that, either messaging to providers or messaging to patients to ensure that everybody knows about these recommendations. These recommendations have, I think, changed the way that people think about medication management. As an example, I'm involved in a large clinical trial that has just started a process of making sure that all the primary care doctors of all the patients in the clinical trial who have had a cardiovascular event or heart failure are aware of these recommendations so that they can help patients decide if their treatment needs to be modified, even though the patients are in a diabetes clinical trial.
Great. Thanks, Dr. Booth. And just to be clear for everyone in the audience, Dr. Booth, it looks like most of your consensus recommendations in the paper that you shared today, that just came out last fall, are now have been folded into the 2019 Standards of Medical Care for Diabetes.
Absolutely.
Is that correct? Great.
Yes, that's correct.
So all you primary care providers out there, just go to the Standards of Medical Care for 2019 because these new recommendations are folded into those.
And maybe I can just add, the American Diabetes Association has made a commitment that as new evidence becomes available, they will update those recommendations. So there are going to be additional disclosures around these classes of medications coming out pretty much every 3 months of the next year. There's just a huge amount of data emerging in this area.
Yes, great. Okay. We have 3 minutes left to close our call, so we will move forward with our housekeeping items to make sure everyone knows how to get their credit and get the survey done. So, Stacey, can you advance us?
I pass the ball to Stacey.
Here we go. We'd like you to think about, we've heard a lot and we've seen a lot in the chat, so we want you all to think about what your key takeaways are. And then your call to action is, if you have a moment, chat in your key takeaways in the chat box right now as I'm talking. We'd love to see those in real time. And then the call to action here is that if you're a quality improvement advisor out there, commit to sharing the 2019 Standards of Medical Care for Diabetes with your partners and practices, and really highlight, the medication section, the lifestyle section, the patient-centeredness that we went over today. And then any providers, prescribers, or educators out there, we really encourage you to incorporate these new recommendations into your practice, whatever your role is in the healthcare system or in the public arena. And then complete the post-event assessment for us. We'd love to hear your feedback about what went well, what could have been done better today. And the Survey Monkey should pop up automatically when we close out the WebEx. And then join us for the next National LAN on Wednesday, May 8th The topic is antibiotic stewardship, and that will be the same time, same place, 3 o'clock to 4:30 Eastern, and you can register because you do need to register to participate and be able to get credit. Also, we have one more Learning in Action Network event in the nation on July 17th. And then, in the meantime, you can follow the QIO program on social media using Twitter or YouTube. And we thank all the speakers today. We thank all of you in the audience for participating. And we're really sorry we couldn't get to all of the questions. But you do have a huge list of resources in the event page. And we hope that we can give you a lot of tools to take away. Thanks so much. Have a great day.
This concludes today's conference call. Thank you for your participation. You may now disconnect. Presenters, please stay on the line for the post-conference.